and Selwyn is currently at the University of Alabama. And after Selwyn makes his presentation, then we will follow up with discussions and input from Dr. Leroy Vickers. Leroy is in Cincinnati, Ohio. Dr. Carlos Page and Dr. Page is in Baltimore, and Dr. Monique Samuels, who is in Atlanta, Georgia. Thank you again for your participation. And after the other doctors respond, then we'll be open for questions. Dr. Selwyn Vickers.
Thank you, Louise. And I appreciate everybody having a chance to be on and to hear about it. It's an important topic and there's a lot emerging. I think the backdrop is that, in our country, I think probably 3 or 4 months ago, we were astonished to have 50,000 new cases a day. Right now, we're at 220,000 new cases a day in the U.S. Almost 300,000 deaths. That number will be surpassed for the end of the year because we have 3,000 people who die a day. And again, we disproportionately make up the cases and the deaths compared to the other parts of the world. So we perform, unfortunately, as it relates to controlling the virus, not well compared to the rest of the world. The infectivity rates across our country, that is the positivity rates of testing, is anywhere from 20 to 40%, depending on where you look at it. And the goal is to be below 10%. So it's problematic, to say the least, that you can get the virus easily. It's easier to get it now just because its prevalence is even higher. So that's the backdrop of why a vaccine is important, and for us to think about taking it when it's available.
Unmute yourself, Selwyn. You muted yourself.
So I won't spend too much time, but what is above the mouse is a 3-dimensional drawing of the so-called spike protein from the virus. And I'll show you what that is, but it's the part of the virus that allows infectivity and creates the biggest immune reaction and response. And so it's the piece that everything's been targeted to make a vaccine from. So not the whole virus, but these early studies are using this piece. Prior to this virus, it took anywhere from 10 to 15 years to make a vaccine to the full phase of development. The quickest vaccine we've had is probably the mumps vaccine that took 3 to 4 years. So you might ask, how is it that we got this vaccine developed in 3 to 4 months? And then subsequently nearly 8 months, have it approved. And the actual time of speed is a couple things. Number one, the concept of next generation molecular biology is what's driven this. And what do I mean? The virus, probably late January, the sequence of the virus was published by the Chinese government after it was identified as one of the coronaviruses. Secondly, within the day that they published it, people took that virus sequence and began to make components of the virus that could be used as a vaccine. Within a couple of weeks after the gene was produced, a vaccine candidate was put into a mouse. Now, what beyond the molecular biology techniques to quickly allow them to do that, what they were doing different was that historically, what was done for vaccine was to basically use the entire virus, but in some way make it not infective. And it would be called attenuating it. So most of the vaccines you take now, like measles, it's a dead measles virus that you're given and your body responds to it. Well, they didn't take the whole virus. They just actually use molecular techniques to make the mRNA of this protein that was causing the problem from the virus, done very quickly. Vaccines had begun their development for two other coronaviruses, the one that caused SARS in 2002 and the other one called MERS more recently. Those vaccines were in development, so they had some data from toxicology that they could use, so they didn't have to repeat all of those studies. So as quickly as they got preclinical, the evidence of efficacy, they moved and submitted an IND, which is a submission of a proposal to the FDA that we think we have a drug or a therapy for a problem, which gives you the privilege, after they approve the IND from the data in mice, to start phase 1 and phase 2 and potentially phase 3 clinical trials. And the other factor that made this fast is that most of the other vaccine studies, the trials actually were done in a serial fashion. You had to complete the phase 1 trial before you could do the phase 2 trial. You had to complete the phase 2 trial before you could do the phase 3 trial. These trials overlapped. They started the phase 1, and halfway through, if nobody was getting sick from the virus and they thought they had the right dose, they started the phase 2 trial. And once they saw benefit in the phase 2 trial, they didn't wait to complete it. They started the randomized phase 3 trial. So they moved very quickly in the context of both the trials. The second piece is that it often took 2 to 3 years to get 30,000 people enrolled. It took 2 to 3 months to get 30,000 people enrolled. So that leads to the speed of 10 months versus 3 to 15 years. Next slide. So as infection goes, we know most of our infections from this virus comes through respiratory exposure. It can come through your eye grounds as well. This will be an intramuscular injection, and it will be an injection that actually allows your muscle cells to make the spike protein and then your immune system to respond to it. There are candidates that are being developed for a intranasal delivery of the vaccine. So a nasal spray candidate, we at UAB are working with a company called Altimmune to push through a nasal delivery vaccine for SARS-CoV-2. So this is the coronavirus. It is a single-stranded positive strand RNA virus. Those little spikes on the outside of it define its capsule, and they create the real problem we face, in both that they are critical for it fusing with the cell, and it also stimulates the immune response in a very, very strong way. So rather than having to make the whole virus or kill it first, what was done was specifically to make this spike protein, specifically the S subunit, that little red part. And so it's not only the spike protein itself, it's actually this S subunit that was done. This type of vaccine, this is from A through, if you would, I. This vaccine is a mRNA vaccine. So it's just a part of the material that codes the genes for the virus. That's what all it is. And it's encapsulated in a lipid nanoparticle. So that it's basically fat cells that they inject the mRNA in, because the mRNA is fairly unstable. And once they inject it in the fat cells and they inject that into your arm, these fat cells or lipid cells easily fuse with your cell membrane and deliver the mRNA, which is then your own cell's machinery make this spike protein in large quantities, which evoke an immune response from your body. So what has been released is the Vaccine-Related Biological Products Advisory Committee meeting data. This was released about 3 days ago before the public meeting of this advisory committee. And this is the committee that approves all new biologics and new vaccines. They give the FDA a recommendation. And the public data was released, I think, on Wednesday. The meeting was held on Thursday, and the vaccine, they recommended the vaccine be approved with a vote of 17-4, one person and one abstention. So there were 22 people. The 4 people who abstained and did not vote for it chose not to vote based on the fact that they thought the age limit should be higher than 16. They felt there wasn't enough data to say that a 16-year-old should get it. They thought it should be starting at 18. That was the only reason they disagreed with it. They proposed to start from 16 to 100 as far as your age. They just felt there needed to be more data to justify a 16-year-old getting it. And they have some data, but not a lot. And there is the one glaring thing is that kids won't be getting this vaccine just because there's not a trial been done yet that will need to be started to know how well kids will do with the vaccine. So there were 2 trials. I should say there were 2 big trials, the phase 1 and phase 2 trial looking just for the dose that would work, which is 30 micrograms given twice, 21 days apart, was done in Germany as a single trial, and then a separate phase 1, 2, and 3 trial with the 3rd trial being randomized was done in the United States, Argentina, Brazil, Germany, South Africa, and Turkey. Each arm of this trial, particularly of the phase 2 and 3 trial, enrolled 21,000 patients on each arm. So there was a 1-to-1 randomization, and the people did not know whether they got a placebo or whether they got the vaccine. Now, the people who took the placebo are given the rights to be first in line now to get the vaccine once it's shown to be efficacious as a reward for participating in the clinical trial. The primary endpoints for this was actually looking to see 7 days after the second dose who got infected. And then there were a number of secondary endpoints. Those who got infected, how severe the infection was, did you require going to the hospital? All of those were factors that they looked at in the secondary endpoints. And they did this actively calling people. So they first examined after the second dose and the first dose, but active surveillance occurred after both doses, and it will continue for 2 years. They looked for reactions to the dose, reactions to the injection immediately after the dose, and there were really no severe reactions. There were 2 people who fainted in England who both had a history of passing out with shots. So the rest, there were no major adverse reactions. The most common reaction was that you get muscle pain from the site of reaction. 62% got some fatigue, 50% got headaches, 30% got some muscle aches, another 30% got some chills, and 14% got fevers. And in general, it's like the shingles vaccine. If you've ever had the 2-dose shingle vaccine, it very much mimics the shingles vaccine. In general, 600 milligrams of Motrin mitigates all of those symptoms. So if you take a couple of tabs of Motrin, most of these go away in the process. So this chart shows a couple things, particularly for us. So there was a fairly equal distribution between men and women in both the placebo and the vaccine. There were 9,000 women, 10,000 men, 10,000 women, 10,000 men in the placebo. So almost the same, 49% and 51%. As it relates to African American, it was about 10% African American, about 20% Latino. Now the Moderna vaccine, because they wanted this number to be higher than 10%, the Moderna vaccine will actually have probably close to 34% African American. It went up significantly. It's certainly north of 20%. But in this case, there were 2,000 African Americans who took the vaccine, 2,000 who got it and 2,000 who got a placebo. In this study, of the 20,000 people who got the vaccine, only 6 people got COVID. And of those 6, none of them were very severe. They didn't have to go to the hospital. In the 20,000 who got placebo, 169 people got COVID. And as it relates to African Americans, the 2,000 African Americans, not a single person got COVID who took the virus who was Black. So 100% efficacy in African Americans. Now the number is small. I'd love to see 10,000, but at 2,000, it's significant. And that is very important to know that for our race, it was 100% successful. This slide shows something else that's fairly impressive, and that is this is a 2-dose vaccine, and that's important to get the 95% effectiveness. This red line shows the incidence of when a person got a shot and it was a placebo, it showed the rate and the number of people who ended up getting coronavirus. And you can see that line continually rise. The blue line shows that if you just got one shot, it was tremendously protective up to 105 days. And that tells you that, you definitely need both, but with one, it provides a significant amount of protection, even just with one injection. And this is impressive. I would say this virus, and these are the first mRNA vaccines we've ever had, but this is better than expected. This final slide shows in multiple age groups, once you got the vaccine, it was asking and sampling for how long the antibody lasted. And in this slide, several up to 100 days, so 3 to 4 months out, people still had high levels of protections from the antibody. So right now, we're making the assumption that we will have to take this vaccine annually. That's the best assumption. We may not. It's going to take, most of the models say it'll take about 60% of the people in America getting vaccinated to break the cycle and create a measure of herd immunity. And the question then after that is, once that occurs, will we need to have everybody take it annually again? Yet to be determined, seeing how we might get out of it. But the antibodies stay around and the durability seems to be good. That's the second reason to get the second injection. We know now that people who've gotten infected with coronavirus clearly are at risk and can get infected again after about 3 months. So we believe these antibodies last longer. So the Moderna vaccine, which will be reviewed this coming Thursday, is as equally effective. We'll have more Black people enrolled. It's easier to store. The Pfizer vaccine, which we've just spent time talking about, requires being stored at -80. And once you take it out, so it's shipped in a pallet of 975 doses. Each vial has 5 doses in it, so you have to dilute each vial. Once you dilute the vial, you can keep it in a regular freezer or refrigerator for about 6 hours. Although after that, they're not saying it's going to be effective. The Moderna vaccine, you can keep in a regular refrigerator for 2 months. So you don't ever have to put it in -80 or dry ice. It works fine in your regular freezer, and it can stay in a regular refrigerator for 2 months. So much easier to use, certainly can get to rural areas easier, and will probably have a higher number of African Americans included. So what has the CDC said about who gets what? And so this is the phase of rollout, phase 1B, 1A, 1B, and 1C. And you can go to the New York Times calculator, put your name, put your county and your age in and your occupation, and it'll tell you in your state where you are in line to get the vaccine. Phase 1A is for healthcare personnel who are actively engaged in actually taking care of the patients. And that's all levels: environmental services, nurses, doctors, PCTs, surgical assistants. All people who are working in the workforce will have access to it. There are several million people who fit into that category. I mean, for Alabama alone, it's about 300,000. So you can look at the size of your state and probably multiply the numbers of people who got it, who have to get that infection. But it's in the millions to get that done. And then long-term care facility residents, they're next in line. And CVS and Walgreens will play a big role in vaccinating the citizens and workers in long-term care facilities. Phase 1B is essential workers, which is a catch-all. It's a lot of people. Teachers, people who work in food and agriculture, utilities, police, firefighters. It's a large number of people. And then phase 1C, which is adults over 65 with high-risk medical conditions. The Pfizer trial and the Moderna trial had people in it with diabetes, heart disease, kidney disease, obesity, and COPD. They all did well and did not get any excess infection and did not have a problem with the vaccine. So they took care of all comers. It also had people who had been infected before, and they did fine too. So it included a broad array of people who would have access to the virus and who might encounter getting it through their local doctor or their public health clinic or hospital. So I'll stop with this. The antibodies made from the vaccine are protective. And it is clear from the Pfizer vaccine and the Moderna vaccine that this vaccine actually exceeds our expectations. We have no therapy, whether it's remdesivir, the Regeneron or Lilly monoclonal antibody that you get as an outpatient, or dexamethasone that can speak anywhere close to 90% being effective. This is the only thing related to this virus that we can talk about being 90% effective, except isolating and staying away from people who don't have it, who have it. So it's better than we would perceive. The bar that the FDA set for approval was only 50% effective. This is almost twice that. And so it's new, it's a new material, it's a new mechanism of delivering, and it appears to be tremendously effective. The Oxford vaccine, which uses a different mechanism to deliver this mRNA, which is done in this case by lipid particles in Moderna and Pfizer, uses a cold virus to deliver it, which infects easily. It's only 70% effective. And so I'm sure it will play a role in much of the world, but it is starting to move toward approval in England. And then the Janssen or Johnson & Johnson vaccine is going forward, and maybe by mid-January, we'll have a third vaccine approved in this country. Its advantage is only a one-dose vaccine. So they're looking at its efficacy at giving only one dose, which will be attractive. And then later on, probably in March or so, the vaccines, there may be the nasal vaccine I mentioned to you going forward. A lot of the candidates, probably in September, there were 130 candidates in research trials and 36 in clinical studies. A lot of them will stop now because one, it's expensive to do, and two, you may not get your money back because you got to hit this target of 95%, which is a really high target to hit. And so if you can't hit that, you would have wasted your money. So I'll stop with that. And then obviously any of our other physicians who are family members, physicians and friends on, I'll allow them to go ahead and comment and certainly take some questions.
Selma, I just wanted to thank you for that very thorough background. I wanted to make a very small point that's come up in a lot of conversations that I've had in the community around the difference between waiting for a vaccine and waiting for treatment. The vaccine is certainly, this might seem something very simple to say, but I'd be remiss if I didn't say it, that the vaccine is to prevent anything that follows along from getting COVID-19, whereas treatment is something, once you get the virus, that something can be done. If you get the virus, the vaccine doesn't have a role at that point. So it's important to be ahead of the curve, right? So that you're not in that group that's then at risk. The numbers and the data that someone's gone through really show us the value, the protectiveness, the way that we can all kind of be safe, not in our bubbles, but also in our communities.
Monique, that's a huge point. This is not a therapeutic vaccine. This is only for prophylaxis. It's for prevention. And she's absolutely right. And this is that message leads to you got to be really safe until you get it, because our therapies are still quite limited for making and helping people, particularly once they get very sick. Janice, my wife, had a cousin who was 60, former football player, healthy, not overweight, got infected, worked at a golf course, 2 days at home, died 2 days in the hospital. And so 71% of African Americans know someone who's had a severe outcome or death from coronavirus. So the data says we die at a disproportionate rate, nearly twice of what everybody else does in the rate of when we get it. And secondly, we know people who've had it. So there is a huge compelling reason for us to take it, because we do poorly with this and have done poorly with it.
Dylan, can I kick off some questions as well? Things that I haven't found answers to. I think one of the things I've heard very firmly iterated is, given that there's still that 5%, masking and social distancing are still important. I wondered if you had seen any data that spoke specifically to folks who are vaccinated, their capacity to carry on and continue to put others at risk.
So Monique asked a really good question, and I'll break it down. Is that what she's saying is that if you get the vaccine, that means you won't, by this study, there's a 95% chance you won't get an infection from coronavirus. But it does not mean you won't be carrying the virus and can spread it to somebody. So we don't have a lot of data on transmission. We know this vaccine keeps you from getting infected, but we don't know how well it prevents you from spreading the virus to somebody else. So what that means is that you could have taken the vaccine, you won't get infected, but you still carry the virus around. And if you don't have a mask on, you can spread it to other people. The data is, there's a little bit of the data in the Moderna study that points that it reduces transmission, Monique, not a lot. This brings the question about who should get vaccinated earlier. Some might argue that college-age kids who are thought to be super spreaders should get vaccinated early if you can prevent them from spreading. But we don't know the answer to that question she's asked. So one of the compelling things to keep in mind, and President-elect Biden has said this, give us 100 days of everybody wearing a mask. Whether you've gotten vaccinated or not, wear the mask. And I think that is really going to be important, because after healthcare workers, doctors get vaccinated, nurses, workers around patients, care technicians, operating personnel, there may be this sense that I don't have to wear the mask anymore, and the rest of the world is going to be looking, saying, well, if they don't have to wear it, I don't. Well, the sad thing is a lot of people could die just short of getting the vaccine because they still got infected by somebody, even though that person was vaccinated.
Can you hear her, Dylan?
I can't hear her.
Okay, we can't hear you. Betty, you can type your question in the chat because we can't hear you. No, we still can't hear you.
Sounds like it was a good question, Ceci.
I believe so, but if you'll type it in the chat, then we can answer your question.
So is everybody on the call have any concerns? Anybody on the call have any concerns about taking the vaccine?
Actually, I wanted to ask a question. I know this had come out. It's Melvin. I guess y'all can see me anyway. So the past, I think 2 to 3 days, there was I saw a news article about people with allergic reactions. They didn't say to what specifically should consider not taking the vaccine. Now, is this people with allergic reactions to vaccines in general, to a specific type of vaccine, like to some certain medications? Like, what did they mean by that?
You know, and Monique or any other physician can speak on. I would say that in general, it needs some specificity, not just that you're allergic to stuff. If you've had a bad experience with the flu vaccine or shingles or measles or mumps, that might be something to consider not taking it if you've had a reaction to those vaccines. Much of the material that is in the adjuvant, that is in the carrier fluid, is the same that's in all vaccines. And if that carrier fluid caused you problems from another vaccine, it probably will cause you problems here. But it needs to be specifically around, I would argue, around the vaccination versus just, I've been allergic, to penicillin, for example.
There's a question in the chat. It says, it's from Kathy, and when can people with underlying conditions get the vaccine?
The Pfizer study took a good percentage of people with diabetes, heart disease, obesity, COPD, all the diseases we suffer with as African Americans. And no one had an adverse problem. And again, those who were Black who had the vaccine, none of them got infected. So it worked. I would say if I'm disappointed in one thing. I'm disappointed in that the rollout of this phase 1, even though it's in phase 1, is that the tail end of phase 1 are older adults with complicated or other diseases. So they come in this third phase 1C, and this is it here. Adults with high risk medical conditions and older 65 are in 1C. So most states will first get a small batch of the Pfizer vaccine probably Monday morning. They'll distribute it to the hospitals, and in that setting, they'll either give half to the hospitals or half to the nursing homes with long care facilities, and it won't be enough. So in the case of Alabama, it will do only 10% of our work, our healthcare providers. It clearly won't be enough. We'll get vaccines each week. The Moderna vaccine will then step up the following week. So we will be getting 2 different doses that will help escalate the time. I'm guessing, I'll be honest, I'm totally guessing, depending on, because I haven't run the numbers and somebody else may know. I'm guessing at the end of February, you might start to have, the end of January, not February, end of January, my hope would be adults with high risk should be starting to get access to the vaccine.
So if you think we had a limited number in the study, only 2,000 African Americans, is that really enough to say it's effective 100% for African Americans?
No, the number 2,000 is small, but the Moderna study is, I would say, is as good or better than the Pfizer. And there were over 20% African Americans. They haven't published and made public their advisory group material like this they did for Pfizer. They'll do that next Wednesday. And we'll see out of the number of Black people who got it, how many got infected. So 10% is not bad. I'd love to see the number be 10,000. But still, it's obviously compelling that even with 2,000 that who got the vaccine, nobody got infected. And the 2,000 who didn't, 6 to 10 people got infected.
So will I be able to say which of the vaccines I want to take after the data comes out about Moderna?
I don't know the answer to that. That's a good question. These both are effective, and the Moderna separation is by 28 days. The Pfizer is 21 days. The Pfizer data shows that one shot really helps. But I don't know that you will choose. What you can't do, once you get the Pfizer, you can't get the Moderna in the second shot. You have to get the same vaccine on the second shot. I don't know, Louise, if you will have a choice. I think it will be less of an issue for a provider to say either is fine because their data are so close. You might argue because there were more African Americans in the other one, that's the one you prefer, and I think that would be a legitimate argument. But, you know, the AstraZeneca, that's at 70%, you might, I agree. If I had a choice, I wouldn't take that one.
So if people of color and African Americans in particular are at higher risk, dying more frequently than anybody else with COVID-19, why haven't we been given some priority?
Yeah, that's a big question. That's a very good question. I don't know why we have not been allowed to move more to the front of the line since we suffer the most. I agree. I think that's glaring. And to me, the data would support. Now, we will fit heavily into the essential worker group, right? Bus drivers, a lot of the areas what we'll call for essential workers are those people who could not work remotely. And we fit into that category pretty heavily. So by some virtue of this second category, a large part of this is going to be our people. But I mean, in England, obviously, you know, they started with their older people first. That was their choice. And they started this week, the beginning of this Monday, just with their older citizens. And I like that. I think the most vulnerable group, many healthcare workers are young and they're not going to get infected or not going to get terribly sick. But I get the fact that because you need healthcare, you need us to be there taking care of patients who do get sick, it makes sense to get healthcare workers done very quickly so that they can still serve the American population. But I think you ask a good question. The essential worker category, I think, will be enriched with African Americans and Latinos.
There's another question from Brittany Benthil in the chat. Is there any data to support long-term side effects of the vaccine?
No, if there's a glaring limitation, our safety data is 3 to 4 months, not 2 years. So we don't know. That's just a fact. We know at 4 months it hasn't created problems for people who got it as early as September, who got the vaccine in a phase 1 or phase 2 trial. We just don't have that data. That's still going to be gathered, and we will know eventually, but we don't know that yet.
Okay, and another question from Betty. Will the doctor let the patient know which vaccine he or she will be receiving?
Yeah, you'll get a little card that will document that you got the vaccine, but also have a space for you to get your second dose. You'll get emailed and you'll get called about your second dose to remind you to come and get it within the time period you need to.
Madam Casson, this is Erin. Can you hear me?
Yes, we can hear you.
Okay. If you mentioned this earlier, I'm sorry. But just in case, let me ask. In some of the news I've heard the discussion around the vaccine spoken about with a little bit of a caveat that, okay, well, great, we have a vaccine, but still there's a lot of uncertainty around how long the vaccine will be effective, and so could we be in a situation where people are still open to it even after they've gotten the vaccine? So is that the case? Is there still, even with the 95% efficacy rate, is that only for a window of time? Is there still research to see how long it will last, or is that going to be, I guess, extensive enough that if we're getting, as you say, the annual vaccine, that it'll be covered for at least that year?
Yeah, so the data looks good, Erin. It's incomplete in the context that obviously people haven't gotten it much earlier than September was probably the first group of people who got it. So we only know from now to then that it's still working. This slide I put up just shows the antibody levels in age groups up to almost probably 4 months. And it's still high levels. They're very high at 4 months. So from what we can see, the way other vaccines work, one is that your immune system develops a memory once it's been infected. And that memory, as it relates to many of our vaccines, lasts a long time. We just don't know yet if this is going to be like the other vaccines. The driver of the frequency of the annual flu vaccine is because the virus mutates so frequently and there's so many different strands. This virus mutation rate is not as frequent. It does, but even when it mutates, it doesn't change its appearance to a level that affects the immune response. So there's not a lot of evidence there's going to be a different strand of coronavirus 2 next year that your immune system wouldn't pick up as the same coronavirus it saw this year. That evidence says that this will have durability, even though we don't have the long-term studies of a year or two to have measured the antibodies and know that that will last that long.
Okay, that's very helpful. Thank you.
Yeah, so right now I would say that the data is good, that it will last for several months and maybe a year and years.
Good deal. Thank you very much.
Betty,
This is Walter Samuel. Everybody hear me okay?
Yes.
Thanks to Selwyn, Louise, and Ceci, and everyone else for pulling this together who's involved. I've got one kind of overall question. Is it fair for me to assume that we should really kind of plan on continuing to live by the CDC guidelines relative to mask wearing, distancing, hand washing, etc., until probably sometime in the summer, whether we get vaccinated or not?
Yes. I think that, probably late spring, early summer is probably correct.
Okay, thanks.
Now, will people do it? I suspect not, but yes, you've got the right answer.
okay, Betty asked will I have the option to ask for the Moderna vaccine?
You know, I think you have a right to refuse it. If they don't have it, you may not have a right to get it if they only have one offering. But I think if you are African American, because of the increased enrollment in it, you will have a right to get it. I think you might hear from a provider because the vaccine is the same type. They're both mRNA vaccines delivered by the same mechanism, that they'll probably push you to take the one that they have available or they have the most of. But I do think you probably have a right to ask because there were more African Americans included in that study.
Hello, this is Nancy. I just want to say thank you so much for this information. But I was wondering, like with the Pfizer vaccine, how it has to be kept at a certain temperature. Let's say in transport, something happens and it's not kept at the specific temperature. Would that harm you when you get this vaccine, or it just won't be effective?
You know, from what I understand about the data is that the lack of the temperature affects its effectiveness. So you might not get as an effective delivery or effective vaccine or mRNA particles that will help your immune system develop an immune response. I don't think it will create undue harm or some other reaction just because it was out of the freezer or out of the temperature range for longer than recommended.
Okay, thank you very much.
And most of the shipments, because of this problem, have a monitor for them maintaining their temperature to the -80, and can each segment, each package unit evidently has a monitor of the date and all of the units in it, but also the temperature as well.
Wonderful, thank you.
I'll just add there, someone that I used to work in the vaccine supply chain space, and this is a common issue across all of our traditional vaccines that people have faced around the world, this kind of temperature management piece. So whereas it's certainly a concern and something we have to be thoughtful and mindful of, there are pieces of technology that have been in long existence and long use to track this, to make sure that the vaccines that are delivered they're efficacious as well as available at the right time in the right place. So I think there's a lot of information that's in place, and we're fortunate to live in the country that we live in, to be somewhat on the better end of that infrastructure.
Monique, would you also agree that if it is in loss to temperature control, it's more about its efficacy versus it creating an allergic reaction or harm?
Yes, I do. I haven't at all looked at the data for the COVID vaccine, but that's certainly true for traditional vaccines.
Wonderful, thank you.
Hi, Selwyn, it's Kathy.
Hi, Kathy.
Hey, I wanted to ask you, what can we do or can you do with your talented self that can help put out more information about getting our loved ones and people of color to take the vaccine? I know a lot, like I have a couple of my girlfriends that I included on the Zoom, they're just a little scared, you know? Is there any way that they're going to, or maybe you can reach out to President-elect Biden and team and see if there's a way we can come up with a way to get people to be more knowledgeable about taking the vaccine? Because I just look at it like, if we don't take, the worst scenario, you don't take it, guess what happens?
Yeah. I would say on this call are obviously a number of physicians, and there are a lot of people beyond physicians who are respected community leaders on this call. And I think it really is going to be trusted voices. We had a seminar, we had a webinar, myself and a couple of pastors, a person over the housing development unit here in Birmingham, and this was on Facebook, and I think 125,000 people tuned in. This was the time that Black people didn't believe they could even get coronavirus. Early on, back in the summer or early summer in March and May, it was, okay, this is a white person's virus, not Black people can't get it. And that obviously, that myth went away really quickly. But I do think it's going to be trusted people who look like us, who we know, pastors, community leaders like ourselves on this call are going to need to take the right to speak up. The data says that only 42% of African Americans will have said they want to take the vaccine. That's compared to about 65% of white people. And the reason they won't take it is because of, somebody's going to inject a tracking device in their arm to control them. For us, it's really the issue of trust and a lack of familiarity and people who we know and trust, and the history of how we've been treated in the health system of America. We have to overcome that, because this vaccine is important for us more than any part of the population of our country. Mm-hmm.
Navia, your hand is raised. You have a question, you can unmute yourself.
Yes. Has there been a lot of research on the side effects if you take the shot with other things? For example, if you take it with the shingles or with the flu shot, is it going to have a side effects with taking the COVID shot as well?
They're typically going to make you wait 2 weeks between taking one of those other vaccines before you take this vaccine. Within a 2-week window, no data. The data shows there are no problems. It must be, Shanavia, it must be inside because you don't have any socks on. I know it's cold in Minnesota.
Yes.
So Kathy, a lot of work to be done. There is a tremendous amount. Ceci will send out, I had the fortune to do an interview on CNN last Wednesday morning on their New York morning show. And I spoke about this very issue of simply getting the broad African-American community with trusted voices to speak to the need of getting this vaccine to our community, to everybody. It's clearly, for everybody needs it, but the most vulnerable population has the least, sign up rate, at least when you query people.
So Selwyn, just to not summarize, but just to give us the specific points that we need to hear in order to say, I'll take the vaccine. What are the salient points that we really need to be saying to each other?
So the first point is, when people have gotten infected, Black people have died at twice the rate of anybody else. We do poorly with this vaccine, with this virus. So whether Milwaukee, Atlanta, New Orleans, Birmingham, when you have 20 to 30% of the population made up by us, 60 to 70% of the deaths occur from us. So we are most vulnerable. Secondly, these studies have included our people in them in reasonable numbers, and in high numbers. And the data regarding them are better than anything we have to prevent the infection. Now, it doesn't treat the infection, as Monique brought, but it prevents it. And the data we see is that when we took it, we didn't get any worse outcomes. We didn't get sick. We didn't get, severe reactions. And we being, I'm using pejorative for everybody, including African Americans. And so everything we have up until this point, I don't want to quote a percentage of remdesivir or the Regeneron or Lilly monoclonal antibody. They are nowhere near 90%. And so when you have something this effective and it has the opportunity to change the course of events and save lives that may not make it if we don't. We should be first in line when it's available. And Louise, you asked the real question, why can't we get it earlier? That is a bigger, to me, more compelling question. But it's going to take people like us, because not everybody is having a call like this. A lot of people are going to be left to their own devices to think about this vaccine. They're going to get their information from their barbershop, their beauty shop, their friends, and that information may or may not be encouraging or accurate. So plenty of reason for us to be messengers, and plenty of reasons from this data that says it's safe, it's effective, and by all parts, it works in us.
Hey, Selwyn, I just wanted to touch on one other little scenario here. When you came on Wednesday, I was actually driving in my car going to babysit the twins. E-learning, that's a different subject within itself. But anyhow, two of my very dear friends are older than myself, recognized you on CNN, and since talking with them, they have decided they are going to take the vaccine. So I just wanted to reiterate to you that you have a calming effect that people, they recognized you. They said, I think that's Miss Kathy's family member. Oh, and they sat and listened to you in detail. And I just know that, you've got some, and some of the other people on the panel, whatever we got to do, we just have to do it. It takes one person to just step up and just try to see if we can reach out to some of these community leaders to get this vaccine. I don't want to see any more of our people dying. It's just to know we just lost a family member. It breaks my heart. So whatever we can do, and, Selwyn, I just wanted to, to give you that compliment. I mean, that was huge because she has been fighting me tooth and nail about getting this vaccine. And she told me yesterday when I told her about the call that she said, Miss Kathy, I saw him. He made me convinced with your numbers and everything, she's going to take the vaccine. So whatever we can do, and, share with me who I need to talk to in my community so we can get people vaccinated, so we can calm this virus down, because I'm living in fear, and that's not good.
No, and I'm thankful, as Louise prayed today, I'm thankful that whatever voice any of us have, or I have, that God would use it to actually encourage people. But I think right now, again, I reiterate, almost everybody on this call has a sphere of influence, and you are leaders at some level. Now that you have this knowledge, you can influence a number of people with some truth versus the fear or what they feel. And so that's a huge opportunity, because we all, as you highlighted, Kathy, there are nearly 40 people on this. We have a sphere of influence. We have a measure of truth now. And now we can multiply that by 5 or 10-fold by who each of us would be willing to reach out to.
Very good.
Can someone give me the name of that interview on CNN, please, to share it with others?
Yeah, because that's what Carol said she's going to do. She said he convinced her.
In the chat, if you open the chat, the link is in the chat.
Oh, thank you.
Welcome.
Selwyn,
Yes.
thanks for pulling this together. Really appreciate it.
Well,
Just
thank you.
let you know,
For sure.
we're joining in from Kentucky.
Good to see you, Sandra.
Uh-huh.